Hello, and welcome to this edition of Let's Talk, presented by the Visiting Nurse in Hospice for Vermont and New Hampshire. I'm your host, Anthony Knox, and I'm the Community Relations Manager for the Visiting Nurse in Hospice. And today's presentation, we're going to be talking about two of our programs that we have here at the VNH, our long-term care program, as well as our Help at Home program. And as you can see, we've got a panel of presenters today for this presentation. We have Megan Hawthorne, John Mitchell-Beam, and Angeline, you didn't write your last name, Marcotte, yes. And to talk about both of our programs. So we're just going to go around first, round robin style, and do some introductions. So Megan, why don't we start with you and just give us a little bit of a background, your role within the VNH, and anything else that you think is important for us to know.
Okay. Hi, Anthony. So I'm Megan Hawthorne. I'm the Director of Long-Term Care Services with the VNH. I've been with the VNH for about 10 years. I started as one of the social workers, and then I moved into long-term care about 3 years ago. And yeah, so that's my history with the VNH.
Perfect. Now, John, how about you?
Good afternoon. John Mitchell-Beam. I have been with the agency for 9 years. I've been had many different roles within the agency, and most recently with the long-term care services for the last 2.5 years. I've been in the medical field for 17 years, and 12 of those years have been in home care, which is really where my passion is.
Awesome. And Angeline.
I guess I'm up. I'm Angeline Marcotte. I'm a retired RN. I've been in healthcare for longer than most of my coworkers have been alive. I came back to work at the VNH about 1.5 years ago, finding that retirement did not suit me. So I work as a home health aide. And it's a very satisfying job. No 2 days are the same ever.
Perfect. So, and we will, Angeline will be giving us a day in the life of a personal care attendant a little bit later in the presentation. But for right now, we're gonna take John and Angeline off the screen, and Megan and I are gonna talk about long-term care. So take it away, Megan. Let me get you to the first slide here.
Okay, so this is the private duty slide. Anthony, do you have the long-term care slides?
It's all in the presentation for the long-term care stuff.
Right. So go back one. That says Help at Home. I think if you can keep going back, I don't think, there you go.
There we go.
Perfect. So, yes, so this is just an introductory slide, Choices for Care in Vermont. Okay, so basically, Choices for Care is a program. It's actually a federal program, and so every state has it. It's named slightly differently in each state. So, for example, Vermont is Choices for Care. New Hampshire is Choices for Independence. And what the program provides, if you're eligible, is assistance in the home. They call that community-based because you're not in a facility, you're in your home, which is in the community. And so you can have a personal care attendant in your home is basically what that means. And you also would have case management. Choices for Care also includes a So if you needed to be in, say, an adult family care home or enhanced residential care or a nursing home, Choices for Care is the program that would pay for that. Okay, next slide. Oh, my screen just... Okay, so what are long-term care services? And I don't want to just read down the slide, but so as I was saying, long-term care services, the point of long-term care services is to allow people who are getting older and who need some help at home or have disabilities and need some help at home, to allow them to remain in their home for as long as possible rather than go to a facility. If that's what that person wants, that's what this program is about. And if you qualify for the program, you can choose to have case management. It's not a requirement. You do have a personal care attendant. That person helps with a lot of different things. I think we'll get to that as we go down the slides. You could choose to go to an adult day center for some days a week. That's a place where you have activities, you can have a bath, you get your meals, that kind of thing, and you get to socialize with other people who are there. You can have a personal emergency response system, which is Lifeline, and also the program can assist with if you need a certain type of cushion for your wheelchair, or if you need certain handrails in the bathroom to help you, that kind of thing. Next slide. Okay, so what does case management do? Your case manager is there really to help you. One thing that a case management really helps with is staying on top of any kind of paperwork or forms that you might have to complete to be on the program or stay on the program. Also, depending what option that you choose, I think we get to another slide, you can have an agency such as the visiting nurses provide your PCAs, or you can hire someone. Let's say you have a neighbor who is willing to help you for a couple of hours every day, and you can hire that person. So that involves quite a bit of paperwork, so your case manager can help you with that. A case manager can help you set goals that you want to achieve, can help you make certain plans for the future, help you complete advance directive, things like that. They really help you with a lot of things. Sometimes I say, in some ways, a case manager can be like a family member in terms of really helping you with all of the planning and goal setting and figuring out of things. So next slide.
So Megan, as far as, for case management, I mean, I know like I've worked in other organizations where I was a case manager for, similar to this, not exactly the same, but are there specific requirements as it relates to how often case management is working with an individual? Are there specific amount of times during a month, a week, a day, anything like that, where a case manager needs to connect with the individuals on their caseload?
Yes, so typically a case manager at a minimum would make a phone contact once a month to check in and see how you're doing. They would make a home visit the other month at a minimum. But if there's something you need help with, come out. It could come as often. I mean, if there was something that you really need a lot of help with, they might come every day for 2 or 3 days in a row. I mean, that's fairly unusual, but if that's required, they can do that. So they have some flexibility.
And then on the flip side, is there a max amount that a case manager can work with somebody in a year, a year's time frame or anything like that?
Well, initially, the expectation is that the case manager typically will take about 48 hours a year to work with you.
Okay.
So what does that work out to per month?
It's about,
That, is
it's,
that about an hour a week?
yeah,
Say,
yeah, roughly, yep.
Roughly. So if you need more than that, you can ask your case manager to apply for a variance to get additional hours.
Gotcha. Okay, perfect. All right, next slide.
Okay, flexible choices. So we were talking, I alluded to this previously. This is where you have flexibility in your program, meaning you can choose between an agency to provide your case management and your PCAs, your personal care attendants, and you would have a case manager, and so everything is taken care of for you, or you can choose to do any of those components yourself. So you can have a program where you do everything. You're given a budget, and then you can hire whoever you want to be your caregiver, whatever agency you want. You don't have any case management, but you have to follow certain rules and regulations. So that's one option. Another option would be you have case management from the visiting nurses, but you hire, like I said, your neighbor or just someone else in the community to provide your services. So next slide. All right, what makes flexible choices different from traditional home-based services? Well, the main difference is that you get to hire your own staff members. So, so one thing is that typically an agency isn't able to supply that many hours. Like sometimes we might be able to provide 3 hours a day, 5 days a week. That would be a maximum. We rarely do more than that. But if you were approved for more than that, then you could go ahead and hire someone in the community. So that's the main difference between getting an agency to provide personal care attendant or hiring your own personal care attendant. And then, yeah, and I see you can change your budget as your needs change. You can apply for more hours as you need them. Mm-hmm.
Okay. And so are there specific regulations as far as, who you can hire and do they need to make, do they have to have specific credentials, education, anything like that? Like what are kind of the rules and regs around being able to hire your own people, rather, family, friends, whatever the case may be?
Mm-hmm. Yep. So mainly the person has to pass a background check, and they have to be 18 or older, and it can't be your spouse who provides personal care, or your spouse can provide personal care, but the program includes other types of care. That's referred to as like homemaking, sort of doing laundry or cleaning the house. Your spouse can't be paid to do that.
Okay, so the spouse could be paid for taking an individual to appointments or out to community events and things like that, but in the home, it would be the expectation that the spouse essentially would be responsible for those homemaking type of things.
Oh, it's not quite. That's not quite right, and it's quite complicated. But
Okay.
basically, so there's personal care, sometimes we call those activities of daily living.
Okay.
And then there's homemaking, which is IADL, independent. What is that? I'm blanking. I have to, but it's I think it's independent activities of daily living. So there's two categories of activities. And so your spouse is allowed to be paid for providing personal care, like helping you get dressed, helping you take a shower, that kind of thing. Your spouse can be paid for. Everything else, the spouse can't be paid for. So laundry, cooking, but also taking you to appointments. Those things are not considered, the ADLs, and so they don't get paid for that.
Okay. Gotcha.
Yeah.
And then as far as the VNH being a organization that can provide the long-term care, case management and PCAs and things like that, from your your perspective as the director of the program, do we have individuals that we're case managing and that they're hiring their own PCAs? Is there kind of a good balance? Do we have more that we're providing more of the PCA coverage, or, kind of how does that all break down?
So I might have to get a little clarification there, Anthony, but so typically, some people do have some hours provided by us and then some provided by someone that they've hired. In fact, that's very common.
Okay.
So a good portion of the people we take care of have that combination. So that's another reason why it's called flexible, because it really is quite flexible.
So it's not an all or nothing, basically.
Correct.
It's, you can balance it between yourself and working with the VNH.
Yes.
Perfect.
Correct. Mm-hmm.
All right. Excellent. Is there anything else as far as from the long-term care side of things that you want to make sure that people are aware of? Because this is the last slide in your section of slides.
I think the main thing that I want people to be aware of is that Medicare does not pay for this program. I think that there was a study that was done at one point, this was a couple of years ago, that showed that a high percentage, around 80 or 85% of Vermonters were under the impression that Medicare would pay for you to have a personal care assistant if you needed one. But that is not the case. You have to apply for Medicaid in order to get that personal care assistant. So I think that it's just good to be aware of that. And, if it's something where, so the Medicaid financial eligibility requirements for this program are broader than straight community Medicaid. So if it's something that you think, oh, this might be something that I'm going to need, but I'm not sure, I would invite people to call Senior Solutions or consult with their financial planner about if this is going to be something that they might need, and if so, what kind of planning should they make for that?
Perfect. All right. Well, thank you, Megan, for going through long-term care, and I'm gonna scoot you off the screen here for a few minutes and bring back John and Angeline as we now dive into the help at home portion of this presentation. So, John and Angeline, I'm gonna let you take it away, and I'll jump to the first slide.
All right. Thank you, Anthony. So the Help at Home program is a private duty, private pay program here at the VNH, who provides personal care assistance to individuals with the goal to keep them safe at home for as long as possible. One of the first questions we usually get asked is who initiates the services? And unlike all of the other programs outside of long-term care program, it could be a self-referral. It can be a loved one who makes the referral, a son, a daughter, a concerned neighbor that's involved with your care can reach out and ask for some services from the Help at Home program. There is no referral needed from a doctor or a primary care provider, or if you've had a hospital stay. We do get phone calls sometimes for referrals from hospitals with individuals who are going home, but an official referral is not required for us to initiate services or continue services after you're on board. So it's a much easier process than the other programs at the VNH, where we don't have to get a medical professional involved. All right. So one of the other thing that we want to figure out first is, what are the goals? What kind of help do you need in the home for personal care, for housekeeping, errands, respite, medication reminders? We'll individualize or tailor a plan to what those goals are for that individual. This is not a cookie cutter service, so things are, like I said, very individualized, and we have that discussion immediately when services are initiated. And they're not set in stone, they're adjustable. So as needs change or increase or need to be decreased, we're flexible with that. We can retailer services to meet the needs of the individual. And we allow our clients to be the captain of that ship. So they let us know what their needs are as they change, and we will move pieces around if we need to, and make sure we're giving you or providing you with the care that you need to be safely at home.
Excellent.
Again, we tailor visit length and frequency to the needs of the client. The Help at Home program has a minimum of 4 hours per visit, and they can be up to 12 hours. We also have the capacity at times to provide 24/7 care. And we can do, so that means we can do visits during the daytime, the evenings, and overnights. The only restriction to the amount of the visit frequency or the length of the visit is our caregiver availability. So if we have several individuals who are able and willing to work 12-hour shifts and overnight shifts, then that's what we'll do. So that's really the only restriction.
And John, why is there a minimum of 4 hours per visit? Because what if somebody just needed a ride to the doctor and back just for a blood draw, and so maybe they need an hour or something like that?
Well, that's really tied to making it beneficial for the PCA. We live in an area, Vermont, New Hampshire, that has some pretty rural towns. And so if we were sending a PCA to a great length of a distance to get to someone's home, and it's only for a half hour, it really isn't beneficial for the PCA. If we can group several visits together at the same time, sometimes we can make adjustments to that, but the standard is a 4-hour minimum. And to address the other part of your question is, we all have had several instances where someone really just needed a ride from the hospital. They didn't have anybody else to rely on and to get settled in the home. So those individuals would agree to the 4-hour minimum. And although we might not stay there the entire time, we would be willing to transport them home, get them in the home, get them settled for what they need. And that may be our only visit.
Okay. Yeah. And then the only other question I have, so is there, I'm assuming that this is just one individual person at a time, not say for example, there were, a couple of friends who, needed this service and things like that. would a PCA be able to provide support to both of them at the same time to do said community activity or whatever, or does it have to be a one-on-one situation?
Well, the regulations stipulate that we provide services to the client and the client only. So we do have actually a couple on services right now where they're both signed up for services. So the PCA splits their time in between the spouses. 4 hours will be spent with this spouse, and then the other 4 hours will be spent with the other spouse, or they alternate which day the spouse is going to get the assistance. So Mrs. may get it on Monday and Mr. may get it on Tuesday. Whatever really kind of works for them and what the PCA's availability is. But again, the specific care has to be individualized for that person who is signed up for services. So it really is a regulation that we adhere to strictly, so that we stay within our guidelines.
Perfect. Okay. All right. And then next slide.
Yeah, the admission to the Help at Home program, it starts with that phone call, inquiring about services, and if we have caregiver availability, we will schedule an admission phone call. Normally, before COVID, pre-COVID, we would just go out to the home and do the admission, but to minimize contact, we have moved to gathering much of the information over the phone. And the information we gather is basic health information, physical limitations, what type of specific assistance you would need in the home. And we also try to get to know the client a little bit. What do they like to talk about? What is their work history? Were they in the military? Were they homekeeper? Just so that it would give them something to talk about, because a lot of times we go into homes where these individuals don't have a lot of socialization. So they seize that opportunity when the PCA comes in to visit, and they do end up chatting quite a bit, whether it's during a respite visit where they're just visiting, or even when they're just kind of puttering around the house, sweeping or getting the laundry done and folding the laundry. They love to chat. And so this gives them an opportunity to have a little bit of insight about this individual before we send the PCA into the home. The other portion of the admission process is signing the documentation and doing a site review. So we schedule a time that's convenient for the client. We'll go to their home. We will review the admission paperwork with them, answer any questions they might have. And then we would just take a look around the home real quick to make sure the home environment is a safe working environment for the PCA. We want to make sure the PCAs are going into homes that don't pose any kind of hazard or risk to them when they're visiting clients. And then after the admission paperwork is all signed, if the client wants a copy of that, we would get them one. And then we would discuss with them which day would be best to start services. And then our program coordinator would set that up, and then the PCA would start to visit as scheduled. The admission process is quite painless for the Help at Home program. It's just asking a lot of questions up front just to make sure we get a good understanding of what the needs are and how we're going to be able to best assist our clients. This is something we get asked quite a bit. Is there a contract? We do not have an official contract that people are locked into. Services can be paused or discontinued at any time, and there's no financial penalty for that. So if someone goes into the hospital and they need to pause services for 2-3 weeks or what have you, then we'll pause services. If they decide they no longer need our help or they find alternate caregivers, we can discontinue services at any time. The only agreement that is signed is the financial agreement, which indicates the client is aware that they will be billed for services and that they will be expected to pay those invoices upon receipt. There's no penalty for canceling services. We do have a guideline or an expectation that if you cancel a visit, it needs to be within 24 hours before the visit, or that visit will be charged to the client. So that's the only caveat to this piece of the relationship.
And then, so as far as, so if somebody pauses the help at home services or discontinues them or whatever, I assume for pause, there's not a lengthy process to kind of unpause it, but do they have to go through the entire process of obtaining the help at home services if they discontinue?
If they officially discontinue services, then we close out the chart or the episode, if you will. And if they wanted to reinstitute services, there would be another admission process. If an individual pauses the services, for instance, they go into the hospital, there is no additional paperwork required if the client's needs really haven't changed. So if they had a stroke, went to the hospital, and then came home and they needed more than homemaking services, they needed a lot of physical assistance with personal care like bathing, dressing, grooming, things of that nature, we would redo a needs assessment so that we could create a care plan that is tailored to their new set of needs. So we don't want to just cookie cutter every situation. So as needs change, we'll redo the care plan. If someone comes home from the hospital, we'll talk to them about the possibility of needing to do a new care plan to directly assist them with what their new needs are.
Okay, perfect.
Like I said a few moments ago, the Help at Home program is a private duty, private pay program. It costs $35 an hour for the first 40 hours, and anything that exceeds 40 hours is $45 thereafter. Invoices are sent monthly around the 10th of the month. And again, the expectation is that those services will be paid for upon receipt of the invoice. Clients are billed for errand and transportation mileage at the IRS allowable rate, which I'm a little embarrassed to say I'm not quite sure what that is at the moment, but the IRS can change that at any time anyway. So if you're curious about that, I would just visit the IRS website to try to figure that out. Medicaid, Medicare, and private insurance companies do not pay for private duty care. So if you have those insurances, they won't be responsible for it. We would bill you directly, and you would be responsible for paying the invoice. There are several long-term care insurances that are specifically for things like private duty care. So we do work with several long-term care insurance policy holders, and a couple things can happen there. Either we bill the client and the client pays us for services and they seek reimbursement from their long-term care insurance company. We also work with two other long-term care insurance companies where we bill them directly. So we send them the invoice and they pay us, and it takes that middleman out of having the client have to pay and to seek reimbursement. So we have a couple clients who are in that program, if you will, and they find it very convenient not having to write a check and then contact the insurance company, because we all know that can be a little bit stressful dealing with insurance companies. So if folks have long-term care insurance, I would definitely encourage them to contact the insurance company just to specifically ask if they cover in-home private duty services.
Perfect. All right. And so we do have, again, Angeline introduced herself at the beginning of this presentation. And so, Angeline, from your perspective, obviously, like you had said at the start, 2 days are the same or anything like that. But, what's your day-to-day, your experience been like as a member of the Help at Home team since you came out of retirement because that didn't suit you?
It's been a fabulous experience, and I have to give credit to my coordinator and my manager for making it a wonderful experience. In terms of clients, the coordinator works very hard to match personalities with the client. And it's always anxiety producing to visit for the first time because I'm basically very shy. But I also have learned to fake it. My role is varied. Mostly, I'm referred to as the housekeeper. So that's doing dishes, mopping floors, cleaning bathrooms, doing laundry. Some clients I grocery shop for and do run errands for. Some clients I take to the store so they can do their own shopping and do their own errands. I also transport people to their appointments, and companionship is a fairly big piece to the clients I have right now. And I usually make time, at least an hour of my visits, usually just sitting and visiting and finding out how their week has been and family frustrations.
And
do you have questions?
Yeah. So is there a specific area that you predominantly do your supports in, or are you do you travel all across, the state?
Well, either. It depends on where the clients are. I've traveled an hour to get to my client, and clients I have right now, some are available to me within 5-minute drive. So it depends on who the client is. But yes, we do travel. I've had clients I live in West Lebanon. I've had clients in Springfield, in Saxons River, and Bellows Falls, Vermont. Right now I have clients in White River Junction, Newport, New Hampshire, in Hanover, New Hampshire, and West Lebanon. So it's clearly dependent on the client.
And since you've been doing this work, have you had clients for a long period of time, short period of time, kind of a mixed bag, kind of how long have you been, what's the longest client that you've been working with? Like, how long has it been?
I have one client that I've had for about a year.
Okay.
And I've had most of my clients are several months. I've had them miss. One client was in the hospital for a prolonged period. So, but we just resumed his visits when he was moved back home. My clients range in age. I've had people in their early 60s and as old as 95, wow, still managing to live at home.
That's awesome.
So it is awesome. And one of my quotes that I will say to people is that everyone wants to save the world, but nobody wants to help mom do the dishes. And I feel that actually by doing dishes, I am saving the world one client at a time.
Absolutely.
And so the most vulnerable population gets to stay in the home.
Exactly. Well, that's awesome. So, and I'm sure I speak for John when I say I'm glad that you came out of retirement, because this sounds like this is the perfect spot for you to be in to be able to provide this support to those that you're providing the support to. So.
And I'll add that Angeline is one of our highly sought after PCAs. Once she gets into a home, people do not want to let her go. And we find that to be true for almost all of our PCAs. Once they get a client gets attached to them, they don't want anybody else. So it definitely shows that they make a true difference in every visit that they make.
I am really blessed to work with a fabulous team, and I really think that our piece of the VNH should be called Care at Home, because every PCA that goes into a client's home feels it's a privilege to be there, and they really do care about the people that they serve.
Awesome. Well, I'm glad to hear that. And so I'm going to bring Megan back into the frame. So so from any of your perspectives, is there any additional information that people should know about, whether it's long-term care, help at home, care at home, if Angeline gets her way and we change the name eventually, any additional information that people should know about from watching this presentation?
I just wanted to thank you, Angeline, for what you shared. Yes, we find that of all the services that we provide, I think that the home health services really mean the most to people, and really, really have huge impact on people that they. It's really heartwarming, and yeah, I think you're right. I think you are saving the world one person at a time.
Yeah, one dish at a time.
Yeah.
Awesome.
Exactly.
I did want
right.
to just quickly. I just wanted to say this is probably more information than people need, but some might find it helpful. So we help people with activities of daily living. There are 12 activities of daily living. 5 are ADLs and 7 are instrumental activities of daily living. And 5 ADLs are focused on personal care, and the 7 IADLs are focused on support systems and surroundings.
Perfect. And John, did you have something you wanted to say?
Yes, I would just let people know that caregiver availability changes from one day to the next, and we do have a wait list. So if people are interested in help at home services, you can give us a call and we'll let you know what caregiver availability is. And if it's none, we can offer to put you on a wait list so you can be the next in line for care. So I do know that other agencies like ourselves can struggle to provide all the hours that the community needs. But if you want to get on that wait list, I encourage you to do it sooner rather than later.
All right, perfect. And again, all of this information is available on our website, vnhcare.org. All the contact phone numbers, everything that you would need to be able to call and ask any additional follow-up questions related to both long-term care services as well as help at home. And with that, again, I want to thank Megan, John, and Angeline for being a part of this presentation, and keep your eyes peeled for a few more presentations as we continue on with November being home health and hospice month. And again, Megan, John, and Angeline, thank you all so much for being a part of this presentation.